this happens in the fallopian tube. When the mother ovulates, her egg enters the fallopian tube, and then the sperm, out of the millions that are deposited at the time of intercourse, about a couple hundred make it to the fallopian tube. And it's that one sperm out of the millions deposited that gets into the egg. So if you're ever feeling down about yourself, you won the best race of your life. You were the one sperm that made it into that egg and produced you yourself. If you move over here, you can see the zygote. That is what the one-celled embryo. So the egg and the sperm by themselves are just cells. They cannot become a human child. You need to bring them together, mingle their chromosomes, and when that happens, you have the initial little human being, a one-celled embryo called a zygote. And this is when life begins. And you can check any science textbook, any biology textbook. This is not a debatable issue. It's a scientific fact. Life begins at fertilization. The zygote moves down the fallopian tube and in the meantime undergoes mitotic divisions, producing more and more cells till it looks like a little raspberry. By the time it enters the uterus, it's called a blastocyst. And this blastocyst enters the uterine cavity at about day 4 or 5. By now we're into the second week. And during the second week, very important thing happens. This blastocyst that entered the uterine cavity attaches to the lining of the uterus. And so this, on this side of the drawing, is the uterine lining, and you can see the blastocyst attached to it. But it doesn't just attach, it burrows in completely till it's completely surrounded by the mother's tissue. So this is the embryo burrowed into the uterine lining. And the very first thing the embryo starts to do is to develop a placenta so that it can interact with the mother. The placenta is an interaction between the mother and the baby. And it forms a unique barrier to keep the mother's and the baby's blood separate. It allows food and oxygen from the mother's bloodstream to pass through to the embryo, but it keeps their blood separate because they're two unique individuals. They are not the same. It's not the mother's body. This is a unique individual in and of itself. So this is showing you a mature placenta. This is what it would look like from the baby side. This is what it looks like from the mother side. This is what attaches. So the placenta is a mixture of maternal tissues and fetal tissues. And you can see in this little drawing here, the uterine lining, and with the mother's blood vessels shooting in the blood of the mother that surrounds the villus of the placenta that has the fetal blood vessels in it. And the fetal blood vessels can pick up the oxygen and nutrients. Most bacteria cannot pass this barrier of cells that separates maternal blood that are surrounding this villus and the fetal blood inside. So many viruses, unfortunately, can pass through. By week 3, so these first weeks 1 to 3 is getting the pregnancy going. And in week 3 is the first menstrual period. So this is about as early as a mother would know that she is even pregnant. But during week 3, this is a picture. By the end of week 3, this is the little embryo. Here's its yolk sac. Here's its placenta. And you can see that blood vessels have already formed in the week 3 embryo. And those blood vessels fuse together in the middle of the embryo to form a simple tubular heart. And this heart begins beating by the end of the 3rd week, beginning of the 4th week, somewhere between 18 to 22 days. You have blood circulating in the fetus, so now it can begin really growing and have the oxygen and nutrients it needs to do so. The embryo is only about 1.5 milliliters long at this point, about the size of the tip of a pin. But notice how intricate it is. It's not a blob of tissue. Like I said, it's never a blob of tissue. Also in week 3, the germ layers form. The germ layers are formed from the cells of the embryo. It starts off as a flat 3-layered, 3 cellular layers called germ layers. And each of those layers, the outer one, the ectoderm, forms the skin and the nervous system. There's a middle layer, the mesoderm, forming the muscles and the heart. Then you have an inner layer of germ layers, endoderm, that has its own set of things that it forms. So it's all set up to get to go. And weeks 4 to 8 are where things get really busy in the embryo, because all the major external and internal structures are established during this time period between weeks 4 and 8. Notice by the end of the 4th week, and here's a little 5-week-old embryo, you can begin to see the upper and lower limb buds are already present. And the skin is translucent, so you can see right through the embryo at this stage. Here's a 6-week-old embryo. Notice the upper limb bud and the lower limb bud, a little more developed, beginning to see a little bit of a wrist and an elbow. And down in the lower limb bud usually lags behind a little bit. At this stage, you can see on the second page of your notes where it says interesting milestones in human development, that embryos show spontaneous movements by 6 weeks. So the muscles have developed enough that you do get some movement. The embryos show reflex responses to touch. And these muscle movements become pretty coordinated by 14 weeks. But they're all too slight of movement for the mother to feel yet. It isn't till about week 17 to 20, when the fetus is bigger, that the mother can detect that movement. And at that point, once the mother detects the movement, it's called quickening. And they used to think that's when life began, is it quickening. We now know with ultrasounds and study of embryos that it began way before that time. Brain waves can even be detected and recorded by 6 weeks. Notice the large head case, the head, and the brain is developing. Here we are, a 7-week-old embryo. Notice that the hand is webbed as well as the foot, but you're beginning to see notches where the fingers are going to be. You can see the little auricle of the ear is developing, the eye is developing, ossification of the bones in the upper limbs start out with a little cartilage model of bone in most of the embryo, and that will be ossified at various times during development. By 8 weeks, this is an 8-week-old embryo, clearly human-looking little embryo. It's about 56 days. And when you measure an embryo, you talk about its crown and its rump, because it's hard, they're always curved. And so you talk about crown, rump length, and it's slightly more than an inch. So it's very tiny, but incredibly intricate inside. Notice that the fingers and toes are now completely separate. So by the end of 8 weeks, you have 10 little fingers, 10 little toes, completely separate. So the embryonic period, there's a major period in human development, and it's weeks 1 to 8. Embryo jismi is a Greek word, which means early stages of an organism's development. So it's not a demeaning term in any way. It's just the beginning of development. And during this embryonic period, all the essential external and internal structures are now present. And by the end of the period, the crown rump length slightly over an inch. And I love this pro-life sign: a person's a person, no matter how small. So even though the embryo is very tiny at this stage, very intricate inside. We have a liver, we have brain, we have spinal cord. The structures are there. Next major period is the rest of the pregnancy, weeks 9 to 38. And this is called the fetal period. And again, fetus is not a demeaning term. It's just a Latin word meaning unborn offspring or child. And during this fetal period, development is primarily concerned with rapid body growth of all the tissues and organs and systems. Notice here we are at 9 weeks, the beginning of the fetal period, and here at 38 weeks. So just a few pictures of fetuses. Here's 11-week-old fetus. Notice the relatively large head in comparison to the body. Fingerprints are forming, begin forming by 10 to 16 weeks. Fingerprints are unique to an individual. Identical twins will have different fingerprints. They'll have the same DNA, but they will have different fingerprints because fingerprints are genetic and environmentally caused. Here's another 11-week-old fetus showing it inside its amniotic sac and surrounded by placental material. Fingernails begin to form by 10 weeks, toenails by 15 weeks. The kidneys are functioning. The kidneys were formed during the embryonic period and they become functional between weeks 9 and 12, producing urine, and the fetus will urinate into the amniotic fluid. It's not as yucky as it sounds because the placenta and the mother's bloodstream is taking away any waste material. So primarily it's peeing water, but it's getting the practice. By 12 weeks here, you can see the little 12-week-old fetus. Taste buds develop during this time between weeks 11 and 13. They've shown that if they inject sweet material into the amniotic fluid, that a fetus will swallow more than it will regular amniotic. So just like a baby loves something sweet, so do fetuses. And the sex of the embryo is now distinguishable externally. The sex of the fetus is or child is determined at fertilization, but the genitalia are fairly similar up until about 9 weeks, and they're not fully differentiated till about 12 weeks. And the crown rump length is now about 3.5 inches. Here's a 14-week-old fetus, and you can see it in its amniotic sac. Beautiful little creature. Here at 22 weeks, a baby can now survive outside of the womb, but typically would need medical attention, especially for breathing. Their lungs just aren't as fully developed as a later term fetus. Here at weeks 26 to 29, this is a picture of a 28-week-old fetus. The fetus often survives if born prematurely. More subcutaneous tissue is now present under the skin. And then by 38 weeks, we have the newborn baby. And it's the crown rump length from the crown to its little rump is about 14 inches. And fetuses that are born at 32 weeks and older usually survive if born prematurely. So the expected time of birth is 266 days or 38 weeks after fertilization. So just stop and think about that for a minute. You go from a zygote, a one-celled embryo, to this newborn baby in a mere 38 weeks or 266 days. It's really incredible. And if you put that in gestational age terms, that would be 280 days or 40 weeks. There's a wonderful video I highly recommend you might want to watch to give you more of the beauty of development. Alexander Cesaris is a mathematician, and he gave a TED talk, and it's about 10 minutes from conception to birth, and it shows some modeling of what human development looks like. And I love how he describes it, the mystery, the magic, the divinity. And so that finishes my talk. I don't know how Lois wants to do questions.
Thank you, Debbie. That as many times as I've heard it, it's still just amazing and fascinating. and beautiful to see the unique development of human beings. So our chat, somehow the chat element got turned off.
No.
I'm sorry about that, but if you have a question, you can email it to me. I can see my email. So my email address is LOIS, my first name, @ortl.org. But I do actually have a couple of questions.
Okay.
So the first one is, should pro-life people use scientific terms like fetus and embryo? Is that a good idea or not?
Well, I use them because I want to show that you can describe the development using regular scientific terms without dehumanizing the infant. So I go back and forth, as you probably heard. I try to remember to say fetus and embryo to be more scientific, but it is a baby. And so I'm conflicted on that. But I think you get farther if you're talking to pro-choice people if you use scientific terms.
Okay, great. The other question is about pain, and when during, of course we have legislation that deals with pain, but also there's, for some, an increased moral issue as well that's kind of related to pain. Of course, our position is that a human being starts, as you said, with fertilization. That brand new human being begins and then develops just like we all did. But when does a developing child begin to feel or sense pain?
Well, that's, as you know, a controversial subject. But I would like to say the brain and spinal cord begin developing very early, right in that third week. I didn't mention it, but the brain and spinal cord have started developing. It starts developing then, and it continues through birth. We all know that the developing newborn to about 3 years of age, there's tremendous growth. So all of that time is what it takes to get a fully developed nervous system. They have determined, and so in the past, they have said newborns don't feel pain. And by the past, I mean the 1980s. I have a son who was born in 1984. And if he had been born with a heart defect and they had needed to operate on him, they would not have given him any anesthesia. Because in the early 1980s, they didn't think newborns felt pain, then it was better to do surgery without it. Well, parents found out about that. I think any parent knows a newborn feels pain. But pain researchers like to talk about the ability to express pain in the same way that people say animals don't feel pain because they can't express it. And so it's just as ridiculous for the fetus. And so they did some research, and lo and behold, now all procedures on neonates are done with pain medication because they find they do better. And that when they do fetal surgery, they're now giving pain medication to fetuses in surgery. The only procedure they do on a fetus without pain medication is abortion. And there are researchers who believe that you really cannot say definitively that a fetus does not feel pain. And there's a recent article out just this year in the Journal of Medical Ethics. And the two authors, one's pro-life, one was pro-choice, but they both said that you really cannot think that a fetus as early as 12 weeks does not feel pain. And they recommended pain medication for children. So that's there was an article, notes on reconsidering fetal pain. So rather long answer, but yes, I think a fetus does feel pain.
I think that's all really essential information for us to understand, and for us to be able to communicate with others. I think that there's just a human, it's part of our human makeup to not want people to feel pain. And so the knowledge that the preborn can feel pain at very early in development, I think is important.
I was going to make a comment.
Yes, go ahead.
Debbie said is that basically, while there may be some controversy about an early abortion, there's no controversy with what you said, Debbie. I think that a later stage abortion in the second or even third trimester clearly is a brutal attack on a living human in an early stage. And
Yes.
that is very clear English. You don't have to actually debate about what words you're using there. And it's just astonishing that we continue to let that happen in some centers throughout the United States.
Mm-hmm. Yeah, dismemberment of a 14 weeks and above child is absolutely barbaric.
Yes.
I completely agree, and painful.
So thank you so much, Debbie. Appreciate that. And we will be sending out your notes. And I really appreciate you summarizing it in a short amount of time as well. There's so much information and so many beautiful things to learn. So we're gonna just launch right into, we started at the very beginning of life. And of course, in Oregon in particular, but in the pro-life movement generally, we talk about from fertilization to natural death, because there are threats to people from whether it's the end of their life or maybe not so much at the end of their life, but through terminal illness and other conditions that they are threatened by legal assisted suicide and euthanasia. And Dr. Toffler, I'm just gonna hand it over to you.
Okay, great. I'm excited to be here and have this time to be with people remotely with virtual means, as we're all having to do. You know, I didn't know what a Zoom conference was a couple of months ago, and I'm about zoomed out now, but I'm really glad that there's a lot of people on this one. I'm going to go ahead and try to share my screen here, and hopefully it'll come up here. So I have had a relatively long background in this area. As Lois said, I've been involved with stopping or trying to stop assisted suicide for the past 26 years. It was in the spring of 1994 when I was actually inspired by the work of one of my colleagues who was an OB/GYN and actually a GYN oncologist, Bill Petty. And he'd asked me if I would be involved in trying to oppose assisted suicide. And I initially said, well, I'll try to get some, give some time to it. And he said to me as he left that day in my office at OHSU, well, I'm going to spend all of the time that I have available, except for eating, sleeping, and working in his office, fighting against it. And within a week or two, that behavior inspired me to try to emulate and do exactly the same thing. And it's carried me through a journey around the world trying to do my best to inform and educate people. And we only have 15, 20 minutes here, so I'm not going to pretend to talk about everything, but I want to give you a sense of perspective and also hope. And I'm particularly going to focus on this country because there are about a dozen countries around the world that you could I'll maybe touch on our northern neighbor, but I want to show where we are right now. And as I do that, I want to share some hope, because it's not just a bleak thing. You hear about assisted suicide or the so-called death with dignity from all quarters, like this is a great option. And yet in 1994, it passed here in Oregon, and you see here a map of the United States. The blue states, there are basically 8 of them, and there's the District of Columbia, which is a jurisdiction that passed by legislative action in that city. And there's Montana, where it was passed by the legislature. But you've got the entire left coast, if you will, and Colorado, Vermont, New Jersey, and the Maine, I believe, and then Hawaii down here. Don't forget out there in the Pacific. So those are the 8 states. Montana's shaded because it really never was passed either by legislature or by the plebiscite and the ballot measure. A single judge, ruled that it would not be against the Montana Constitution. And so you have at least a doctor or two in that state that is participating in ending the life of people under whatever arbitrary circumstances. By the way, I use the word physician-assisted suicide. This slide says medically assisted suicide. Those are accurate terms. The so-called medical aid in dying, or just plain aid in dying, are euphemisms to describe what really is a total conflict of interest for physicians, or for anyone really, because in general, we believe that all human life is inherently valuable. I once remember listening to Bernard Nathanson up in the state of Washington when he was here giving a talk, and he said something to me and to the audience that I'll never forget. He said that all social engineering is preceded by verbal engineering. And we just heard a little bit about how important word choice is. I try to make myself, if I ever carry that term, aid in dying, or medical aid in dying, or so-called death with dignity, I will always use that so-called, because I don't want to carry water, if you will, for the devil, because that's exactly how you change. If you use accurate terms to describe what you're saying, the interest and enthusiasm for the topic drops by about 15%. So how people do polls is critical. And suppose you say that the solution to suffering is the end of life of the sufferer, which is accurate. That seems a little bit harsh. And now you might say that, gee, Dr. Toffler, you're making this up. This seems extraordinary, and you're choosing words that are so charged. Really? Well, in the state of New York, they sent patients with COVID or had not fully recovered of COVID to very high-risk people. In Belgium, which is another jurisdiction that allows not only assisted suicide, but euthanasia, they literally didn't admit people to the hospital because they were old with COVID, and we'll just let them pass away and die. Now I'm getting sensitive. I'm getting older myself, and so the idea that you're going to treat me differently at this stage in my life than you did when I was 25 is, I think, an anathema to equal treatment under the law. I have a 102-year-old cousin who is absolutely intact, mentally sharp as a tack. We don't always agree on politics and all. He and I had a vigorous discussion a couple months ago, but he is no less valuable at 102, and he should deserve every bit of treatment. I mean, it's the whole discrimination that we're talking about today everywhere. This is at the heart of discrimination when you start talking about ageism or treating people differently because of their color or their background. The whole notion of this kind of differential treatment is at the heart of discrimination and racism. So I want to show 40 states here then, actually more, because the District of Columbia is one of those 10. So 41 states have not embraced this. And you might ask yourself, after 25 years, is this such a great idea? Why haven't they embraced it? And it's because not just me, but there are literally hundreds of thousands of people, including groups like the Not Dead Yet group, that recognize that when you start talking about some people's lives aren't worth living, that they're talking about the disabled and discriminating against them, and how horrible that is when you think about the vibrancy of people who sometimes are disabled, have to use a wheelchair or artificial legs. I mean, they're young people like this sometimes. This courageous vet who was doing bomb disposal and unfortunately triggered an IED, the improvised explosive device, and blew his legs off. He is a wonderful example of embracing life despite the tragedy that happened to him and to his colleague who unfortunately died. So he has this is my celebration of my Alive Day. And so this is what we ought to do. If people feel discouraged, if they feel like they've had a completed life, and that's enough criteria in Belgium or the Netherlands to have not only assisted suicide, but actually euthanasia. What's the difference? Assisted suicide is where I help you to kill yourself. Euthanasia is where it's being done to somebody, whether or not they actually have requested it. And that's literally true in many jurisdictions in the world. So I'm just going to give you a brief smattering of some of the major arguments. And many of you I know on this call are very familiar with these things, but this notion of radical autonomy, and I want to end my life because to me it makes sense. So it's so-called rational suicide. I've never heard that term at OHSU until one of the people in the psychiatry department early on back in the late 90s used the term rational suicide. Where did it come from? She made it up. There was no literature suggesting that at all. And when you talk about this, this is an important thing because there is a piggyback effect. There is a spreading of suicide. And you look at it right now in states that have passed this, their suicide rates generally are above the national average, including in Oregon. We may not be the top, but we're right up there in the top 5. They talk about intractable pain. I might as well be dead because my pain can't be controlled. It's not even among the top 5 reasons why people choose assisted suicide in the state of Oregon or anywhere. And it's not even necessarily pain that can't be relieved. It's the fear of pain. So the fear, the notion of wanting to be able to guide my own course, autonomy. And then number 3 is really talking about all kinds of fears. I'm afraid of what I'm going to have to go through. I'm going to die anyhow, and so I need to end my life. Well, you know, think of that. I'm going to die anyhow. I don't know what disease at this point, but you know, I might as well not have to worry about the rest of my life. Is this what they're saying? I want to have control and the safeguards. Even if I don't end my life, having this toxic substance in my medicine cabinet makes me feel better. This is what is being said by some. And then the most, I think, to me, turning the words on their end is to say it's dignified to end your life. And so my late wife, 6+ years ago, whose life ended because of a terminal metastatic cancer of leiomyosarcoma of the uterus, we had 5.5 years we were blessed with before finally the cancer took her. And I treasure every day that we had together. There isn't a day that goes by, even at this point, that I don't think about that relationship of 40 years and her having blessed me with 7 children. We now have 22 grandchildren. Was her death because she died naturally at home surrounded by family? Was that undignified? Was the death of Jesus Christ on the cross undignified? No, it was a horrible death, but it was the most dignified. It's like Maximilian Kolbe, we're going to celebrate in a week, his passage where he laid his life down for another prisoner to get out of Auschwitz. And so it's crazy, these terms of dignified is an abortion of the word dignified, because dignity doesn't come from killing yourself. It comes from the acts that we do in our life, that where we love one another, we're willing to sacrifice for one another. So why are we against it? It's killing. It's situational killing. Some lives aren't worth living. The solution to your suffering is I'm going to help you kill yourself. It's a terrible message, and I'm going to show you a couple little quick vignettes of why that's so dangerous. The safeguards that are in place are protecting physicians. It's the lowest level of care. You know, I'm in the process of starting a practice with 4 other colleagues, a Catholic practice that will be unique in Portland, if not all Oregon. And we'll get off the ground in a month. But we just bought malpractice insurance because we're held, if you do assisted suicide, to the lowest standard, like the Good Samaritan rule. But I may not have any expertise, but I tried to do good, and therefore I could defend myself. That's the safeguard in here. It's an incongruity to try to say you're a healer and you're also a killer. I mean, my analogy is like you're a lawyer for the defense, and your defendant that you're defending is a little surprised when you walk across the courtroom, and now you're on the plaintiff's side, and you're basically now trying to argue for your death. And you know, if it's a death penalty case, think of this. You're also the judge deciding which argument is the best. Should I live? Should I die? Should he be killed or not killed? And then worse, you're also the executioner. So if there isn't role confusion in that, I don't know what there is. Doctors are fallible, and I'll show you this videotape that'll illustrate that very well. As a person was going to be qualified for assisted suicide because she didn't want to have treatment, and we see that she's made it many, many years after that incorrect prognosis. And then legalization pressures on physicians, because if you don't do this, you shouldn't be a physician. Just like if you don't do or refer for abortions, you shouldn't go into medicine or OB/GYN. This has already happened years ago in publications, peer-reviewed publications. It's remarkable. So I'm going to give you a little brief vignette. Barbara Wagner was a school bus driver here in Oregon. She was retired. She had metastatic lung cancer. After a couple years of remission, it came back. Her oncologist prescribed chemotherapy to slow the cancer growth and reduce her symptoms. It would not actually cure the cancer, but it would statistically give her about a 50% increased chance of being alive in 1 year. The Oregon Health Plan said the chemotherapy would not be covered. In the same letter saying that you couldn't get treatment that you and your doctor wanted, they said her assisted suicide drugs would be 100% covered. No copay, nothing. And so the medical director is featured in this next little clip. I'm going to show it now.
Her doctor offered hope. In this bottle, the new chemotherapy drug, Tarceva.
Like my doctor said, maybe this can put the lid on it and stop it.
That hope shattered with this letter from the Oregon Health Plan, telling her we were unable to approve the cancer treatment. It will pay for comfort care, including physician aid in dying, better known as assisted suicide.
I told him, I said, who do you guys think you are? To say that you'll pay for my dying, but you won't pay to help me possibly live longer.
We took our concerns to Dr. Sam Saha, chairman of the commission that sets policy for the Oregon Health Plan. She says, to say to someone, we'll pay for you to die, but not pay for you to live, it's cruel.
I don't think anyone's saying that. That's, I think, maybe an unfortunate interpretation of the letter.
Assisted suicide critic Dr. William Toffler calls the message disturbing.
People deserve relief of their suffering, not giving them an overdose.
And he says the state has a financial incentive to offer death instead of life. Chemotherapy drugs like Tarceva cost $4,000 a month. Drugs for assisted suicide cost less than $100.
Is it cheaper to pay for somebody to die than to help them live? That is not a question that we think about. We don't think about investing our healthcare dollars in that way.
Yet when thinking about patients like Barbara Wagner, Dr. Saha admits they must consider the state's limited dollars.
If we invest thousands and thousands of dollars in one person's days to weeks, yet we are taking away those dollars from someone.
So you see financial incentives come in not only in medicine, but think about relatives. I've never asked a patient, do you have a life insurance policy and who is the beneficiary? You can see those conflicts, and they have come out in public where these are nefarious things that can happen. 1 out of 10 seniors, elders are abused, 1 out of 10. The ultimate elder abuse is to abandon the person with giving them the health care, or worse, actually trying to end their life quickly. So this is a real quick story. Dr. Stevens is in the upper left there. Jeanette Hall is to his left, your right, and she's there. She basically had a cancer prognosis that was bleak if you didn't get something done. She didn't want to, it was inoperable cancer. Ken Stevens, my colleague, who's the co-founder of Physicians for Compassionate Care Education Foundation, is the doctor involved. And I'll just let them tell the story of how she was eligible and she actually voted for assisted suicide, and this is the story.
I couldn't believe death was at my door. And I thought, surely that can't be right. Death, he's saying 6 months to a year to live. It was life and death. I just knew I didn't want to suffer. One day I was bleeding so bad that they had to take me by ambulance to the hospital. The doctor came in and said, Jeanette, you have colon cancer. And it didn't hit me. I just went, I have to go. I have to take care of my mother. I have to do my work. I have to go. And they said, you don't understand. You have cancer.
When I first met Ms. Hall, she had been evaluated by her surgeon. Her surgeon had determined that the cancer was inoperable, meaning that it could not be cured with surgery. So he referred her to me for radiation and also chemotherapy. she immediately told me, she said, "I'm not here for the treatment, Dr. Stevens, I'm here for the pills. 2 years ago, I voted for Oregon's assisted suicide law, and that's what I want. I'm here for the pills. I don't want radiation, I don't want chemotherapy."
I reached that point without hope. I was sinking into depression.
I said, "Miss Hall, would you come back and see me next week? Let's talk about this some more." I was able to get better acquainted with her, and I learned that she had a son who was attending the police academy. He was in his late 20s. And I said, "Miss Hall, wouldn't you like to see him graduate?" He was single. I said, "Wouldn't you like to see him get married? Does he know what you're considering here?"
It made me realize there was hope. There was something to live for. And I thank him for that one sentence that brought me back to reality and made me try.
So she did accept the treatment. She received chemotherapy and radiation. She lost her hair temporarily, but the tumor just melted away.
Dr. Stevens, if you had believed in physician-assisted suicide, I wouldn't be here. You didn't give up on me. You didn't abandon me, and that's why I'm still here. These are the kind of doctors we need that give you hope when your hope is gone. Here I am 15 years later, and I went to my son's graduation. It's great to be alive.
So Jeanette is now 20 plus years out. I last saw Jeanette myself when I was at OHSU in my last year about 8-10 months ago, maybe a year, and she was alive and well, and she's just as sprightly as can be. She's almost ageless. You don't see any difference. So I'm going to conclude with, if I can get out of this thing, let's see, there we go. So in summary, I believe that assisted suicide is really not compassionate care. Compassion means to be able to suffer with people. That's what Ken Stevens did with Jeanette. He didn't just say, "I'm a vending machine, you want assisted suicide, pull this letter." So dispassionate, like, I don't care whether you live or die, that's your choice, you're autonomous. That's what assisted suicide is. It has to be. It's dangerous. She could have had a doctor that was a vending machine who, and many of the doctors here, there's about 120 that gave prescriptions last year in the state of Oregon out of about 14,000 doctors. And so if you have a couple hundred assisted suicides in a given year, which we do in Oregon, almost 200 that ended their life, that means each doctor is participating, is giving out more than one, and they are now referral sources, if you will. They're thanatologists, probably is a better term for them. They're specializing in ending people's lives. There are really no safeguards to be sure. There aren't conflicts of interest among family members. There are problems with diagnosis. Now people who have diabetes, like Ken Stevens himself, would be eligible, because if he stops using his insulin, he could literally die in less than 6 months without insulin. He could have diabetic ketoacidosis. He could go into a coma. He could die. So that makes him now, according to the Oregon Health Division, eligible. The safeguards are like wet tissue paper. And there are clearly compassionate, life-giving responses to requests. Dr. Stevens illustrated that in a vignette. And I'll stop here and take whatever questions. I'll stop sharing my screen and be glad to talk with you with what remaining time we have.
Thank you, Dr. Toffler. Those videos always get me. I did have a question. So it's the law in Oregon. It was great to see that you are right, that it hasn't spread, but what are practical steps that we can take as Oregonians to protect ourselves and our families or people in our community against physician-assisted suicide?
Well, great question, Lois. And I think, unfortunately, it has spread. I didn't mean to say it hasn't. I'm saying that it hasn't spread like they predicted literally back in 1998. After being tied up in court, it finally passed muster, and the first death occurred in early January. And Derek Humphrey, who's kind of the founder of this movement, who's still alive and kicking, he said it's going to be like dominoes. And thankfully, the truth has gotten out. So what is the truth? I would be sure, what is your doctor? Ask your doctor. Ask her or him what she or he thinks about assisted suicide. Because if they're okay with it, I personally would say, you know, I need a doctor who, even when I'm discouraged, that will encourage me and help me and be willing to be with me, to suffer with me through my illness, as a family did with my late wife, Marlene. If you don't have that, you're at risk. If you have people who collude with your desperateness. I mean, think about this. If somebody came to you, had nothing to do with illness or medical, just said, I'm thinking about killing myself, what do? We try to reach out and help. Gosh, tell me about that. What's going on? Why would we dichotomize end of life or an illness and change our attitude to the person? How is that devaluing? So be sure who your doctor is. That's first. Then if your loved one needs hospice, unfortunately, if you look at the statistics here in Oregon, almost 87% of the patients who are ending their lives are in hospice. Now, I'm not saying the hospice is causing this, don't get me wrong, but I'm saying I want to go to a hospice that doesn't do this, that doesn't encourage me. And you want to ask about the hospice as well. At first, the hospice workers had to stay outside the door when this was going on. Now they're going into the house, and they're literally, it's hard to know when are you enabling, at least, if not promoting this. And literally some people feel that they have to go through with it because they've gone down this path. And I just wish some of these people promoting it would say, you know, you don't have to. I've gotten to know you. Let's change course. You've got a lot of life left in you. Do something to encourage the person, for heaven's sakes. So watch the hospice. And then the other thing is, this talk could have been about advanced directives as well. Do not sign that you don't want things done to yourself. You can't predict the 6,000 different scenarios that might happen to you. So up until the last 4 days, we didn't have my late wife, Marlene, do not resuscitate. The reason is because you don't have as many things done for you if you have that. You don't have as many antibiotics. You're not as likely to get admitted to the hospital. And if you get in the hospital, why put you in the ICU? Because you're DNR. Well, because the ICU is intensive care. Sometimes you need intensive care. And so don't label yourself DNR until literally it's checkmate and you know all the circumstances, and then it may be appropriate, but I'd be reluctant even then. So at any rate, those are the things that come to my mind. There are lots of good organizations that help you ferret this out. The Patient Rights Action Council in Ohio with Rita Marker has living documents, so you want to live. And how do you fill out these advanced directives so you're not actually jeopardizing your life if, God forbid, something bad happens to you?
Yeah, thank you, Dr. Toffler. And we do have an Oregon version, and it's a organization that basically we've created so that people will be interested in it, called Conclusions Oregon, and it is a current. The guidance is the more important than the actual form, is how you fill out the form and the guidance. So we've developed that as a resource and have sent that out. And then also, yeah, Rita Marker is an amazing resource for a lot of different things.
Right, Lois, and I'm glad you brought that up because it's called a protective medical document, basically. And so the most important aspect of all that is who would speak for you if, God forbid, you can't speak for yourself. You've got to talk with a family member, trusted loved one. And so I filled out who would speak for me if I can't speak for myself. And my kids would be the ones, and I've labeled the ones that are a little older than the younger ones, and also that are in medicine. I designated 3 different people so they can, and I trust them. So that's what we need to do. And do not just say, I don't want this, I don't want that, because you don't know what the circumstances are. And using the organization Lois talked about would be great.
I do have a question from Teresa. So Teresa, you are going to need to unmute yourself. Oh, there we go. Go ahead, Teresa.
I was just wondering, what is the best way to talk to someone who is considering physician-assisted suicide? What are the best arguments to use to convince them that that is not the right way to go?
Well, very, very good question. The first thing is to explore what's going on. I mean, I can't possibly come up with an argument against it without understanding where they're coming from. So just as I said, gosh, you must be hurting. Tell me about that. And then do a lot of listening. This is not something that takes a lot of time. I remember having just that exact scenario with a patient I'd never seen. I was in urgent care of our clinic up on the hill, and it was a guy who was a contractor, but he was in a wheelchair, and he was a very ambitious contractor that had done lots of things. And I knew about construction sites, and I said, how in the world are you able to do that with this? He had an advanced form of multiple sclerosis, which is very, sometimes it's indolent. His was more aggressive, and he had a 17-year-old daughter. And I found out about all his life. He'd come in for something else, but he said, you know, yeah, it is hard, and sometimes I get a little discouraged, and if it gets much worse, at some point I might be thinking about just ending it. And I said, you know, I listened to him until he's done talking. I said, you know, gosh, I hear what you're saying, that this is really, I wouldn't know without you telling me how bad it is. On the other hand, I want you to know that if I were your doctor, I would want to take care of you and help you get through the disability and the difficulties that you're describing. And I think that your life, to me, is inherently valuable no matter how disabled you get. And I think if your 17-year-old daughter were here, she would say the same thing. And he just said, thank you. And so we have an impact, and how we react to people, is it going to be that kind of tone, or is it going to be, yeah, I see what you mean. So if you get feeling too bad, you know, I do that. Not that often, but sometimes I help people when they're really in tough straits and giving them an overdose. It's really astonishing. You know, in that video, it showed the mechanics in the sense of it's only, at that time, $100 to kill yourself. The cost of that drug has gone up to about $3,700, and it's not even available now. Seconal and barbiturates. That was a rapid way to overdose people. Now that's not available, so they're working out a combination of 4 drugs, DDMP or DDMA. A is for amitriptyline, and they give 100 to 200 times the normal dose for each of those ingredients: diazepam and propranolol, morphine, and I'm missing 1D. At any rate, the bottom line is that you're giving massive doses, and still the person's there not dying right away. The average time is about an hour and a half, an hour to an hour and a half. So I thought this was death with dignity. You know, it's just not very pretty. And if this comes out, if people realize that this isn't taking a pill like Hollywood and you slip off to sleep, there are people who wake up 67 hours later and say, you know, I'm quoting, what the hell happened? I thought I was supposed to be dead. You know, thankfully that guy had an epiphany and said, you know, I think God wants me to kill myself. There's about a 2-page article in the Oregonian of all places describing this. I mean, it's a wonderful outcome. The wife is greatly relieved because she didn't want him to do this, and she misguidedly thought the right thing to do to love my husband is to go along with his wishes, as opposed to lovingly, gently pushing back and saying, you know, I love you. I don't want you to leave us. You're important. You're important in my life. I don't care how disabled you are. I just want you to be in my life until your natural end. And that's the loving response. That's the compassion. And we'll get through this together. Sure, there'll be suffering, but there'll also be great joy, as there was with my late wife and my family. And I wouldn't trade a nanosecond of those sometimes very challenging times, and other times just incredibly joyous times. And it's just horrible to think about wasting that.
Just a quick note to add, in addition to the advanced directive, when people go to the hospital, they may be asked to sign those POLST, that hot pink form. And it's really important that they think twice about that or look into our information, because not everybody needs to sign that. And you need to be very careful with it. So that POLST form, P-O-L-S-T.
Very well said. I'm glad you brought that up, because that is a dangerous form. There's a 31-page white paper that we wrote. I'm a co-author on cathmed.com. The Catholic Medical Association has the white paper on underscoring everything Joan just said.
Thank you so much, both of you. So the website that Lois mentioned earlier is Conclusions Oregon. You can print off a copy of an advance directive there, Conclusions Oregon. Is it .org, Lois? I think .org or .com both get you there.
Yeah. Yes.
But if you don't have a printer, you can just call our office at 503-463-8563. And we can mail you a copy too. We want everybody to make sure that they have an advance directive. So thank you so much, Dr. Toffler and Dr. Canepa. And we're